Thank you very much for APT Medical having me again in such a nice environment and such a nice meeting here. And I am very happy to share my experience regarding the APT products, which fascinated me um, amazingly. So in 2024, CTO, APT launched their wires, and in that live case, we were able to manage the live case with APT wires and with APT materials, and this is I get from the Turkish distributor. This is what I get from the Turkish distributor from October to April 2025, 29 centers, 27 different CTO operators. These are the centers that use the APT products. And now we are over 350 cases we have done only with APT wires. And we finished with only APT wires. We were able to do that to finish a CTO procedure with only APT products. And these are the statistics, and we had a 92% of success rate, and the 300 cases of these 300 cases, more than 150 cases are my cases. And the thing is, only in 8% of these cases we needed a different wire. It was a puncture wire. 80% of all these cases we need either conquest or hornet to puncture. Otherwise, the 92% of the cases were finished with only APT wires. And the reverse cut was about 18%. We had a 20% of retrograde approach. So these were actually very complex cases. And you can see the distribution of the wires here. And this is the JCTO score of these cases. And let me give you an example how I use these wires in my daily practice. So this was a we had this was a very challenging case for me. I have done 3 days ago, and we had first problem in the I'm doing my approach is always radial. I'm a default my access is radial, and I'm doing my procedures. If I'm not puncturing, if I'm doing the exercise by myself, it's always radial. So we had a problem first here. You can see we had a dissection there. The guiding catheter couldn't advance, so I thought something is happening there. And then I used the Anyreach wire, and with this Anyreach wire, I passed the lesion. It was 0.6 gram. 0.6 gram is the usual default floppy wire, workhorse wire that I usually use. And then we have the P version of it as well. And the P version has a polymer jacketed sleeve, but the tip is still a floppy wire. So skip this. Come on. So we did balloon assisted tracking here. Okay. It's not working. Okay, let me do it like this way. So we did balloon assisted tracking past the lesion, and then we faced another problem here. It's the extreme subclavian anatomy. We had a subclavian tortuosity, and here comes the dual shot. Double shot. It's not a good shot here. The problem was we couldn't engage the left main, so I had to fish the left main, and then I put an expressman into the left main to understand the anatomy here. The problem with this case is we have an ejection fraction 20%, and the LAD territory is totally scar tissue. Okay, and the LAD is totally scar tissue, and the problem here is we don't have any support device. No ECMO, no impella or something. But the only territory that is viable is the RCA segment here. So we had to do something to this patient to increase the ejection fraction here. And my intention was to put a retrograde wire to reduce the contrast rate, okay, and then puncture antegrately with a just marker approach towards the retrograde wire here. That was my intention. That was my preparation. And it was not easy to find the, let's do it this way. It was not easy for me to cross. I tried the first, second, third septal, and there was the second septal here. I tried a lot, even with different wires. I was not able to go. Then I used again an Anyreach 0.3 gram. This is the P. It wasn't septoepicardial, and then I went through. This was the 0.3 gram. We have a C version and a P version. And a P version I usually use when to cross epicardial collaterals. But in septal surfing, you can use the P form, but the C form is more useful in that sense. So I crossed the lesion here, and then we used the along it was the 1.7 along. They have the 1.7, they have the 1.9, and they have the 2.6 French. And my default microcatheter is 2.6 French. But my intention here was no harm to the patient, no harm to the septal, no harm to the collateral, because if anything goes wrong here, then I'm in big trouble with this patient with the ejection fraction 20%. So I wanted to go a very safe procedure. So the 1.7 didn't go, but I have my wire in the distal vessel there, and then here I tried anti-greatly. This was the Anyreach 6 gram P. The P 6 gram, Anyreach 6 gram P is a polymer jacketed wire. It has the edge curve and it has also the straight one. Okay. If you have some side branch coming out and if you want to skip the side branch, it's sometimes very useful to use the ash curve. So then you can easily puncture towards where you want to puncture. But in this case, I used the 6 gram. It was an ash curve. I was able to puncture anti-greatly and and find the true lumen here. But then I had another problem. I have a 2.6 French anti-greatly, and I don't want to go retro. And let me show you this one here. Okay, here I find the true lumen anti-greatly. So this is the 6 gram find the true lumen, and it went into the PL. Okay, then here comes the. Okay, so then the story began here. We had a balloon uncrossable CTO. Okay, a long 2.6 from 6 French is tapered tip is a very strong microcatheter. Okay, in calcification, usually I don't have any problem. Sometimes there are cases that if I compare it with Corsair Pro, with Corsair Pro XS, the Corsair Pro XS, even in some calcified lesions, the tip breakage happened, and I leave the tip there, and it happens. And with this one, I never experienced that, but I felt the crinking of the microcatheter I felt it gonna fell off. I stopped, and when I take out the microcatheter anti-greatly, it was damaged. The anti-greatly was very damaged here, and so this was the anti-grade passage. Come on, okay. So what I did, the 6 gram is in the true lumen. I don't want to give contrast, but I feel that I'm in the true lumen by understanding how the wire is behaving inside the coronary. So I used 1.0 balloon, didn't cross. I used Tornus, didn't cross. I used the rotowire to cross, the rotowire didn't cross. And I used anchoring techniques, guide extension techniques, and then I did granuloplasty 3 times. Okay, it didn't work here. The granuloplasty didn't work either. And then I wanted to do the subintimal anchoring technique. I wanted to go around the calcium antegrately. I don't want to go retrogradely. I don't want to put a bulky microcatheter in the retrograde system because of the fear of the complication with the 20% ejection fraction patient. So I did all the maneuvers that you can read in the Brilakis book, okay, but it didn't work. So what I did was, here you can see this is the Yeah, then this is the knuckling of the Anyreach 6 gram. I went antegrately, Anyreach 6 gram, I knuckled it down. It was not easy to knuckle it down, but somehow I found the subintimal space here. Now I have the knuckle with the 6 gram, and then I did a subintimal anchor into the subintimal place. I did subintimal ballooning to modify the calcium, and it didn't work either. Okay, so this is that part here. Okay, I put a 1O balloon. This balloon is in the subintimal place. I'm trying to, for the last time, push with the 1O balloon over the lesion, but it didn't work. So, okay, come on. So then, my last resort was okay. I cannot cross this lesion until I have my wire is there, but nothing is crossing antegrately. Not the rotowire is crossing antegrately. Then my last resort was okay. I look at the pressure and everything, the patient was fine, the contrast was low, okay, I go retrograde. Then I took the 2.6 French along, okay, the 1.7 didn't go, the 1.9 didn't go. That's usually my experience. For example, if you have a caravel that doesn't go retrogradely, okay, if you have any low profile, braided microcatheter, pushable microcatheter that didn't work, okay, then you need a channel dilator. And for me, the 2.6 French is the best channel dilator on the market. Okay. So, and it's not only me that is saying that. Very experienced operators have the same experience with me. And I resorted to this 2.6 French here. It took me more than 10 minutes to go down. I had to be very patient, you know. It took me down, but I had no any other option here. The 2.6 French is coming retrogradely. And come on. Okay. So we have the 2.6 French there. And I always look at the pressure, okay. When the patient has no pain, still no pain. And then here I was able to on the distal cap. Then the patient felt pain. The blood pressure began to drop at this stage here, but it was still okay. I had to act very fastly, and you can see the 3 gram P, and then I was able to knuckle the 3 gram P into the aorta. Here you can see it's in the aorta. 3 gram it's a polymer jacketed wire. They have the P version, they have the straight version and the H curve version, and you can choose according whether you have a side branch or you have a curvy CTO to puncture. You can choose accordingly. And here, because I did 3 times granuloplasty and I did it subintimal ballooning here, I was very lucky that my 3 gram P knuckled into the coronary artery and then went into the aorta. But then the blood pressure was low and I had to act very fast here. And it was already 3 hours procedure. So let me see what I have done then. Okay, so this the tip of the 3 gram. The beauty of this Anyreach wires is even if the tip is destroyed, okay, you are still able to manipulate the wire and you can still direct the wire because there's a robust wire and the tip you can divert in any direction. You can see I'm in the guiding catheter and then I cannot bring the retrograde microcatheter into the antegrade guiding catheter because the blood pressure is very low. I don't have any time. I have to do something very fast. And as you can see, I did tip in here. So I was very lucky here again. And the tip in was into a 2.6 French, 130 centimeter long, another along 2.6. And after the tip in, it took me just 1 minute. Claudia, I was lucky. So for your portal study, I put this also into the registry already. So let me see what we have done here. I'm almost done. Okay. So, and then what we have done is we brought the antegrade microcatheter down. As you can see, it's going very nicely. I don't have to return it. It goes down, and then I change the wire, and then this is the end result. We lost the PL here, but we had an osteal disease or something, and the story doesn't end. We have a retrograde, filling of the LAD. Something must happen to the LAD, and here is the LAD after check because the patient has still pain. And here is the LAD. And I checked the collateral. You can see the collateral. I did tip injection here. The collateral is okay. And then this is the LAD. So you see the LAD is gone. And I had to restore the flow. I went easily with a 0.6 gram Anyreach. And then left the LAD as it was before the procedure. So I restored only flow because this territory is totally scar tissue. Okay, but somehow I had to restore at least flow to the septals. So this was the case. I have another case, but if we have time, it was a case I have shared in the Turin CTO. So, but I think we have to discuss with Manfredi also, and with you guys as well. Summarizing it, in my usual practice, we have zero point 0.6 and 0.3 gram C and P version. In the donor artery, in CTOs, in the donor artery, I used to use extra support wires. For example, if I'm doing an ADCTO, I put an extra support wire into the RCA in order to stabilize the donor artery guiding catheter. Okay, it helped me a lot. But then uh, I realized that the extra support wires, I experienced some kind of perforation sometimes. Okay, they have the risk of doing perforations like whisper extra support, Siombolo extra support, or choice extra support. You have to be very careful when you place them into the donor artery or in another artery. And I realized that using 0.3 gram C as a donor artery wire helps me a lot. So in the donor artery nowadays I use 0.3 gram because it has moderate support opportunities. I use 0.3 gram as a donor artery wire. I use it for regular. It's a little bit expensive than the other one, but for regular PCIs, I use it also entering the septals. I use it to surfing the septals. It's a versatile wire. You can use it for many purposes. So it's a very mm, versatile wire. So the floppy wire, the Anyreach zero point 0.6, is the regular floppy wire like run through. Okay, so there are some operators saying that it has better features than the run through, but I am not so much a run through user, so I cannot compare it with run through. But that's what my colleague said to me. And then we have the CTO wires, the 1.5, the 3 gram, the 6 gram. And then we have the micro catheters, the Expressman, and the whole portfolio for a CTO procedure is there, but we only need a puncture wire. That's what I am saying. So thank you very much.